Can you hear me? Am I audible? Can I put some background here? Can you hear me? Am I audible?
Yes, Dr.
Yes,
Ruchika.
ma'am.
Yes. Good evening, sir. So actually, Dr. Rao had messaged me. If so, should I message him that we are ready to let him in?
Yes, yes.
Yes, ma'am. Yes, ma'am. You can.
Okay. Or should we wait for some more participants?
You can wait for another 5 minutes, I think, Dr. Ruchika.
Okay, sir. Has I think Dr. Gaurav has finished his OT, na, sir?
Yes, he was on his way from the clinic, and there was a mad rush on the way. So he just called me about 5-7 minutes back. So he should be reaching any moment and logging in.
Okay, okay, sir.
Yeah.
Good evening, sir. Myself Sundar from MyHealthscape, based out of Mumbai office, sir. Happy New Year to you all, and thanks for making us to be a part of this interactive session, sir.
Yeah. Good evening, Mr. Sundar. Yeah, it's a pleasure to participate in this webinar, and we are really looking forward to learning from Dr. SKR, sir.
Superb, sir. Thank you very much, sir. I've been always heard about you, sir, and I've seen your presentations, money, names, and all another thing, but never had a chance to directly interact with you. So it's been really honor, and I'm excited in meeting you and talking to you, not though in person, but do virtual platform, sir.
Yeah, so I think you can, kind of express that to my brother, Dr. Gaurav, because I'm the retina surgeon here.
Okay, hi. Okay.
He's caught in traffic on the way.
Okay.
Yeah, he joined, sir.
Yeah, he should be reaching any moment.
Yeah, no issues, sir.
Good evening, Dr. SKR, sir.
Good evening, sir. Sir, you have to unmute.
Yep. Good evening.
Sir, also
Good evening,
joined.
sir. Good evening.
Hi, sir. Good evening. Myself Sundar from MyHealthscape. Thank you very much for the opportunity provided to us, sir. It's a pleasure meeting you, and Happy New Year to you all, sir.
Thank you. Wish you all the same. Yes.
Thank you very much, sir.
Yeah. Good evening, sir. Gaurav here. I'm sorry, I just made it. There was a big traffic jam on the way. I'm so sorry for being late.
No problem at all. No problem at all. We just got him anyway, so we can start whenever you guys are ready. No problem.
We are all set, sir. We are all set.
Right. So,
guys anchoring
yes.
the whole. She's our cornea expert, so she's the holding ground with you.
Okay. Sir, should I start then? Should we start?
Yes.
Yes.
Do we have most of our team with us? I mean, I'm sorry,
Yes,
I'm logging from the phone, so I'm not aware.
I can see most of our doctors, sir.
Okay, perfect.
Okay.
So I think
good evening, everyone. Welcome to this meeting on dry eye diagnostic and treatment modalities. And I'm very, very happy to share that we have amongst us Dr. S.K. Rao sir, who's going to be speaking to us on this topic. And he's the guest speaker for this evening. And it gives me immense pleasure to introduce him to all of you. Sir is an alumnus of Shankar Nethralaya, Chennai, where he also worked as a senior consultant for nearly 15 years. And he's currently the director of Darshan Eye Care and Surgical Center at Chennai, which he founded in 2006. And he has trained extensively internationally also with legends like Dr. Falcinelli and Dr. Mellis. And Sir is known for his extensive work on complex corneal and ocular surface disorders like Stevens-Johnson syndrome and surgeries like keratoprosthesis. And he has nearly 200 publications in peer-reviewed journals to his credit. Sir is also the editor and reviewer for many prestigious and highly ranked scientific journals, both national and international, like Cornea, British Journal of Ophthalmology, and JCRS, just to name a few. He is also a member of the International Steering Committee for MOKP surgery, and he has authored several books. And he has also been the president of the Cornea Society of India. So with this, I welcome you, sir. And I'm happy to welcome sir, who is the teacher of my teachers from Shankar Nethralaya. Over to you, sir.
Thank you, Ruchika. Thank you, Dr. Gaurav. Thank you, Dr. Gupta. And thank you, MyHealthscape, for this. This meeting actually has a very interesting evolution because I had a call from the MyHealthscape team saying that somebody was interested in looking at the IRPL. Would you mind having a conversation with them because they have some doubts? So I said, sure, because this year I'm actually on a sabbatical from talks. I'm getting the Zoom fatigue. So I said, fine, I'll do the talk. So then Ruchika sent me a very polite email saying that we'd like to have this discussion. Is it okay? So I said, yes. Then she said, can we do it on Zoom? So I said, yes, we can. Then I told her, let's keep it like a round table. Whatever questions or doubts that are there, then I'll be happy to, whatever little I know, I'll be happy to share it. Then she said, sir, can you do a 10-minute talk first so that we can have a little bit of a background and then we can go on to the discussion. So that's how this talk evolved. So I've actually just put together a random set of slides. I'm not really sure exactly what is it that is interesting to you. And I'm just trying to cover the ground, try and share with you my perspective on this particular problem. And then I believe we have at least 15 to 30 minutes to discuss this thing. And so if there's any specific areas of interest to you, I'll be more than happy to talk about that. I think the MyHealthscape team needs to enable me so that I can share my screen. Somebody has to make me a panelist, I guess.
And while they are enabling you, it's a personal pleasure for me to welcome sir. And he was one of the gentle giants duo, which I would say along with Dr. Mahesh Anugam sir, for all of us, sir. Although I trained in retina, but we always used to look in awe upon Dr. SKR sir and Dr. MPS sir for anything and everything. So it's a very special feeling for me to welcome you.
I'll share a secret. I'm still in awe of MPS. he used to do buckles faster than I could do cataract surgery. So I think he still does them as fast. I think Sundar, you need to do this.
Yes,
I think.
yeah, I'm just figuring it out.
Okay.
Because Imran is the host and Imran is unmuted, so I'm just calling him, sir.
All right, no problem.
Yeah, just a second. I thought I can bypass it, but it's not allowing me to do it.
You probably need administrative privilege.
Administrator status, correct. Hello, Imran. Yes. Who's doing it? Yeah. Okay. He's just getting it done for us. Sir, couple of minutes, sir, please. 2-3 minutes, we should be there.
No problem.
Yeah, thank
So
you.
basically, for this dry eye business, what I was trying to put together is that I always feel that when we talk about dry eye, to me, it looks like we're looking at this problem through the high magnification of your slit lamp or your microscope. We seem to take one particular area and focus in depth on it. I think for me personally, when we are talking about dry eye, as I'll try to share with you in a couple of slides that I'm going to put up, I like to zoom out, go up and look at it in a larger perspective, because I seldom think that these things exist in isolation. We always think of dry eye as a particular, when I go to meetings, I find people talk about etiology, classification, tests, and it goes through one particular format. Unfortunately, the dry eye doesn't seem to conform to those, and most of the patients, by the time they reach us, they have a fairly complex interplay of various things that are going wrong on the surface. So unless we can actually pick up these various events that are happening on the surface, it's my personal belief that we'll never be able to address the patient's problem satisfactorily. So that is my whole concept, and that is where a large part of this talk is coming from. Although we will focus on specific areas, I think Ruchika was telling me that you all are interested in the new diagnostic modalities that are now coming up, which allow us to document and record many of the changes that are happening on the surface. And she was also interested in this modality of using the light-based treatment for Meibomian gland disease or dysfunction. So we will definitely cover those two aspects of it. But some part of my talk will be talking about trying to actually look at this whole thing in its proper perspective and not get too caught up on these small details. And let me see if I can convey that message across in the next 15 minutes or so that Ruchika has allotted to me. So I have a bunch of slides. They're not in any particular order. It's just some random thoughts that I was trying to put together last evening when I was putting these slides together. So I'll try and share those, and then I'm sure there may be specific questions that you all may have, and then I'll try my best to see if I can answer at least some of those today. Which diagnostic instrument are you all using at the moment, Ruchika?
So we are using the IDRA, the Ocular Surface
IDRA,
Analyzer by
okay.
Meniscus.
Okay. The same one that I'm using as well. Okay, so I find it's quite, it is convenient, it's useful because it saves some time in the clinic because the optometrist can do it and then you can get a nice printout and look at it. Yeah, so it does offer some advantages, but as we shall see, you can also do these similar tests clinically as well. And I think the idea is finally to get the information that we want for that particular patient, because if we don't know what we're looking for, then all of those details that are there on the printout may not really make all that much sense as well, unless we can actually put it together properly. So, oh, I think they've put me in now. So let me see if I can share this now. Okay, I'm screen sharing. Can you see the first slide?
Yes, sir.
There's a picture
Yes.
of, yeah, okay. So basically we wanted to talk about dry eyes today, and we also wanted to talk about the testing process itself. And this cartoon seemed particularly appropriate. So here's the patient who's come in saying that he's got dry eyes, he's got very sensitive eyes. And then we shine very bright slit lamp lights on his eye to try and look at what's going on. So this seemed appropriate when it comes to testing. So we need to do the appropriate testing. Just to start off with this concept that I was trying to talk about before I could get my slides on. If we look at a disease like cholera, everything is very clear. We know it is caused by this organism, Vibrio cholerae. We know what it does in the system. It creates a tremendous fluid imbalance. It does that by creating, diarrhea, which is really explosive. And we know what to do in this situation. We hydrate, we basically give some antibiotics, and ultimately, of course, we're treating the patient. Now, in contrast to this, even after doing this for 30 years, when it comes to dry eye disease, I'm still puzzled as to what are we treating. Like the Vibrio cholerae in cholera, do we know what exactly is happening in that patient? What is the pathophysiology? We know we talk about the fluid imbalance that we saw in the Vibrio cholerae induced cholera. What do we know exactly what's happening in a dry eye disease? So what we're ultimately ending up doing, I feel, is that we're treating the patient's symptoms. And if you want to go one step above, and if you're really interested in this condition, we're trying to treat the ocular surface, which is suffering in patients with dry eye disease. But what sometimes we forget in our interest in treating the patient's symptoms and trying to look at the surface is forget about the patient himself. Because this is largely a psychosomatic disease. I'm sure all of you are familiar with the scenario that I'm going to tell you now. I see patients with tremendous changes on the ocular surface who are just not bothered. They said, doctor, I just came for my glasses. You're telling me a lot of stuff about my surface. I'm very comfortable. Just give me my glasses and I want to go. Then there's the other patient in whom I basically can find nothing wrong with his surface. I've done the IDRA, I've done everything I can think of. But he sits there for half an hour and he's constantly telling me there's some itching here. When I try and explain this, then he tells me there's some pain here. If I try to explain this, then he says there's burning on the surface. If I say tell him something about that, then he comes up with some discharge. So he doesn't want to leave. So I can find nothing wrong, but he's got enormous amount of symptoms. So both of these categories we have to worry about. Now, we talk about dry eye. It's all very nice when we do the meeting. We look at it in, like I said, in very clear segmental patterns. We read about it and all that is fine. But this is an actual live patient who comes to the clinic. This is a 60-year-old lady. She's single-eyed. She's lost this eye due to absolute glaucoma. You can actually see the total cataract and the edema here. This eye doesn't see. She's got only one eye now. And she's been treated by somebody for a long time now. She had an episode of what her doctor called viral conjunctivitis 2 months prior to this episode when I saw her and I took the pictures. He treated her with antibiotics. He treated her with antivirals. He gave her NSAIDs. He basically gave her tear substitutes. The condition kept getting worse as he kept adding medicines. Then finally, he said, you may have an allergy to your glaucoma medicine, and he put her on brimonidine and he took away the dorzolamide. And then the patient who was 618 or so before went down to 660 and she comes in a panic. And this is technically what we term quote unquote dry eye. So you look at her, she's got aponeurotic ptosis. You can see the congestion. You can see the light reflex on the cornea is shattered. It's not very clear. She's very photophobic. I couldn't get a better picture than this of the left eye. You can see the papillary change on the upper lid in the palpebral conch. You can see the same changes in the lower fornix, although the fornix is deep, so there's no cicatrization. At least there's no ocular pemphigoid. And then when I do my staining, I do the fluorescein staining, and you can see the 360-degree staining of the cornea. It is not matched by conjunctival staining, which I've tried to look for using lissamine green. So the conjunctiva just stains a little bit in the left eye, hardly stains in the right eye. But you've got almost 9+ staining with the fluorescein on the cornea. So there's a disconnect between the corneal staining and the conjunctival staining. So this is what I was trying to say, that unless we can pick up things that are happening on the surface, dry eye is not necessarily a simple disease. This is another guy, again, just random pictures from the collection. This is a patient who had a wonderful multifocal IOL done in each eye by a good friend of mine. He's got 6/6 and 6 unaided vision, doing very well from the cataract surgery point of view. But he claims that ever since he had his surgery 3 months ago, his eye is troubling him. He can't see clearly. The vision is fluctuating. It's blurring. He's irritated in the eye. He finds it hard to read for long periods of time. And this is how he looks. You can see the external appearance. You can see a little bit of brow elevation here. You can see the frontalis acting. And then this is how the eye looks. Nothing really. As you can see, the cataracts have been supremely well done. There's a bit of congestion in the interpalpebral area. There's a bit of tear stasis that you can see. You can see the height of the tear meniscus reflected here. It's a little higher than normal. You can see that the lid's sagging a little bit. You can see just about see the lower lid punctum over here. So basically, if you want to put together what's happening on this patient, you can see the orbital fat prolapse, which is quite considerable. You can see the dermatocalatic folds of skin, which is pushing down on the eyelid, both sides, more on the left side, and he's trying to compensate by using his frontalis here. So that's the frontalis overaction to overcome the brow ptosis that he has. So these are pretty much aging-related changes in the periorbital region. If we look at the eye, there's a lax lid, like I said, there's a little bit of eversion, there's mild Meibomian gland dysfunction. He's got a bit of conjunctivochalasis. You can see the role of conjunctiva here and here. And that's causing the disturbance in the tear excretory patterns. You're seeing an increase in the tear meniscus. And there is a mild congestion showing that there's some inflammation that's going on the surface from all of these. So he relates everything to the surgery that was well done 3 months ago. But what he has is a lot of changes on the surface. And again, this is somebody who also gets casually labeled as a dry eye because he has irritative symptoms on the surface. So neither of these two patients, the previous one and this one, will get any better if you just give them tear substitutes. No matter which one you use, you can use the highest level of tear substitute that's available today. But if you're only going to use it, he's not going to get better either on the surface, or he's not going to be convinced about your treatment. So this was just what I wanted to start off with, basically to tell you that it's better to zoom out and not just focus on the tear deficit or just the dry eye, but try and look at everything that's happening on the surface. And of course, the tear problem is one component of what's going on, but you do need to pick up the other components as well. So can we look at tears in isolation? And if we do choose to do so, what do we do, or how do we go about it? So I think we should still look at the whole picture. But if you just want to look at the tears in that particular patient, how do we go about it? And this is the famous cartoon or schematic from the Deuce 2 report. So they basically said you ask questions, and if the questions seem to suggest that the irritation could be due to a tear problem, then they said you basically do a questionnaire, either the dry eye questionnaire 5 or the OSDI. And if it triggers a response, for instance, if the OSDI is 13 or more, or the dry eye score is more than 6, then you think that could be a dry eye issue. You confirm it by looking for a loss of homeostasis. So you do an NIBUT. You look for the osmolarity, because a dry eye, the tears do get more osmolar, hyperosmolar. And then you look at the ocular surface staining to look for the effect of the lack of tears on the surface. And if any one of these is positive, and then you do confirm that, yes, there is a tear problem on that person's surface, then you try and categorize them as evaporative or aqueous deficiency dry eye, because now we believe it's a spectrum. We don't no longer believe they're two distinct entities. They basically have some component of each. So you want to place them somewhere in that spectrum. And in order to do that, you can measure his tear meniscus height. You can basically do a mammography. You can do a lipid interferometry and do these things. Now, the problem with this for most general ophthalmologists who are not sitting in institutes are you don't have access to NIBUT. You don't have access to osmolarity. You seldom have access to mammography. You cannot do lipid interferometry, and you cannot measure tear volume by measuring the tear meniscus height, because 5 out of these 6 things actually need a device for you to do. There is a cost to the device, and there is a cost to the patient every time you use the device. So it is quite disheartening for the general ophthalmologist who wants to do something for his patients with dry eye when he sees a schematic like this, where you need 6 parameters, 5 of which you can't access. And the only thing you really can do is ocular surface staining with your fluorescein or your lissamine or your rose pegol. So the other question during the course of this discussion is, how can we overcome this? And if you really have these devices, are they really, how can we make the best use of these things? How do they add value to what we're doing? So if you're in the clinic, I guess you can still do a wonderful job. You do have access to the OSDI, so you can quantify the patient's extent of symptomatology, and you can use this to serially follow him up after you've treated him 2 months, 4 months, whatever. You can look at ocular redness, which is a surrogate measure of ocular surface inflammation. You can do a fluorescein BUT, and as long as you're doing it in a consistent and repeatable manner, you can get useful information from this. Although the NIBUT is technically more physiological, because you're not adding fluid with fluorescein first to measure the BUT, you're measuring it in the native state or the virgin state in the eye by using the breakup pattern of the Myers on the cornea. You can stain with fluorescein and lissamine. You can do a Schirmer, which gives you some measure of the amount of tears that he has. And you can, of course, do a Meibomian gland assessment clinically as well, apart from looking at mammography and apart from looking at lipid interferometry, and we'll see what that is. If you do have access to one of these newer devices, then you can, of course, get more information. You can get an NIBUT. You can basically measure the tear meniscus. You can look at the Meibomian glands, both in terms of their anatomy and in terms of their function by doing a lipid interferometry. And if you're even more sophisticated and you're sitting in a tertiary level institute, you may have access to a tear lab, which measures osmolarity. And you can also measure with the, the MMP9 device. You can measure the actual quantum of MMP9, whether it's less or more than 40 nanograms per mil on the surface, which tells you how much of inflammation is going on the surface. So this is the more sophisticated way of doing it, but you can get reasonably good information in the clinic by doing your clinical methods as well. So this is the IDRA, and I'm sure, for people at Drishti, this is it's not news, but Ruchika did mention that there would be a few other corneal specialists as well. So I'm just showing you what it does. It does the NIBUT, so it projects the Maya, and then it looks for the breakup, and it tells you based on the color, the time at which it breaks up. So you can have an idea of where it broke up and how quickly it broke up. You can do this tear meniscus height measurement, although this is semi-quantitative. The machine doesn't do it for you. It gives you a magnified image of the tear meniscus. You still have to place the markers so that it will measure it for you. You can do a lipid interferometry. This is not like the lippy view. It doesn't actually tell you the exact thickness of the lipid layer, but it gives you a scale based on which you can assess whether it is normal, decreased, or what. You can look at the Meibomian glands very nicely. The infrared mammographer does a good job, and you can get a redness score as well if you want to quantify it using the CCLRU scale or whatever you want to use. You can take a picture and have an idea of how much redness there is. And this is the device that does all that. It also does a few other things like looking at pupillometry. It looks at the blink reflex, how complete it is, and so on and so forth. And it gives you a very nice tabular column. This is the older version. The newer upgrade now gives you an even better version. So basically, this is nice because you can have it as a record in your file, and it's easy to show this to the patient and explain basically. So any marker which is in the red means that that particular value here, the eye blink, is abnormal. Anything which is in the green, like here, the Meibomian gland anatomy, is normal. And anything which is in the yellow, like the NIBUT here and here, possibly is suspicious. So it's color coded, it's easy to pick up, so you don't need to remember values and so on and so forth. So it does have a value. It does give you some good stuff. So if you have access to it, of course, you would like to use it. It documents things a lot better for you. So where do we start this whole process? I guess, of course, we want to listen to the patient's symptoms first patiently. And then we want to assess how severe the patient thinks his symptoms are. So this is very important as well, because if we understand how much importance the patient gives to his symptoms, then we can tailor our responses accordingly. Then, of course, we need to look at the signs on the patient's eye, and then we need to assess for ourselves how severe those signs are, because symptoms are to keep the patient comfortable. What I am more interested in is to make sure that the ocular surface health is maintained. I don't want epithelial breakdown. I don't want stromal thinning. I don't want infection. I don't want melting perforation. So I'm more interested in this set of data. And ultimately, of course, we know that in this condition, there is often very poor correlation, like I started off by telling you, between the patient's symptoms and the patient's signs. So we treat this, and we do treat this with a pinch of salt. At some point, we may have to put our foot down and say that, yes, you have something, but it's not being borne out by what I'm seeing. And then we can basically tell him that we should stop at some point. So when we're looking at the lids, what I try and do, basically, I'm trying to share with you my approach. It's not necessarily the only one or the best one or whatever, but it's just mine. And of course, I'm happy to hear from you when we discuss how this can be bettered. Like I showed you in that elderly lady, she had aponeurotic ptosis. Some people with thyroid disease have a wide stare. So I want to know where the lids are. I want to know how lax they are, particularly the lower lid, because if it's very lax, there's tear stasis, which leads to inflammation. I want to look at the blink completeness and the blink rate. Somebody with Parkinson's can sit in my clinic for 3 to 4 minutes without blinking at all. So he just keeps staring at me. So that's going to play havoc with his ocular surface. I want to look at the closure of the lid on the slit lamp. There could be lag of thalmos. And if I have any suspicion that it's there, then I ask also about nocturnal lag of thalmos. So these are things that you want to look at. Like I told you before, the dermatochalasis also plays a role, because if you have a heavy roll of skin pushing down the lid, the patient's scared to blink. Because if he closes his eye, it takes a lot of effort to open it again. He brings the frontalis into play and so on. So his blink rate automatically comes down. So when I look at the patient with a dry eye complaint or a complaint that suggests a dry eye, I will look at all of these aspects of the lid function as well. The lid margins, you want to look at the lashes. Lash loss is good. It tells you there's a lot of blepharitis. We want to look at misdirected lashes. I want to look at the Meibomian glands, about which we'll be talking later. Look at inflammation along the lid margin. And of course, the new kid on the block, the Demodex, look for cylindrical sleeves along the base of the lashes. You want to look at the tear meniscus, get used to looking at it. You don't necessarily have to measure it each time. If you look at enough patients, when you look at all your cataract patients who are quote unquote normal, you'll get a good idea of what is a normal adequate tear meniscus. And then you can judge whether it is depleted or whether it's excessive in a given patient. You want to look at the quality of the tear film. You don't want to see a lot of mucus threads floating in it. You don't want to see rainbow colored interference fringes in it. And you want to look at the stability. You don't even need fluorescein in some of these bad patients. Even as he blinks and opens, you can see those dark spots appearing on the cornea where the tear film is receding. So all this tells you that he has a short BUT, and of course he will be symptomatic. In the conjunctiva, both on the upper lid, the lower lid, and in the interpalpebral area, we look for papillae, we look for follicles. Basically, papillae can tell you that there's some kind of an allergic process. Follicles could mean a viral infection, could mean medication toxicity, could also be with allergies. You can look for congestion, look for the location of the congestion. Is it circumcorneal? Is it only in the lateral or medial canthus? Is it in the upper limbus? Is it in the lower area? Each of these has a significance. Look for any gross irregularities on the conjunctival surface, which can interfere with the tear film. And of course, look for keratin, particularly in the medial canthal region, because that is an early specific and sensitive sign for OCP. And look for any cicatrization, which can indicate either a past conjunctival damaging condition or a present ongoing process. In the cornea, the most important thing is the luster. It must be smiling at you happily. So when you put the slit lamp on the cornea, you must see a nice circular spot with sharp edges, not that diffused out image that I showed you in one of the pictures. Look for the presence of filaments, look for the presence of peripheral corneal vascularizations, scars, and other corneal irregularities, which can cause patient symptomatology. Don't forget other structures. Just because you're dealing with a surface problem or a dryness, look for the AC reactions, look for iris changes, look for the retinal changes, which sometimes happen in a condition like SLE, which can also cause anterior segment changes. Look at the optic nerve and, of course, the lens, because sometimes these people are on steroids and you can see changes from that. Atopic keratoconjunctivitis, which causes surface changes, causes lens changes, and so on. So in other words, like I said, zoom out and look at the entire process, not just focus on the tear meniscus or the tear volume alone, because then I suspect we may not get the right answer much of the time. Now, one of the things that I like very much is the fluorescein stain. I do it a lot, basically because it helps me to look at the tear meniscus in greater detail. And sometimes after I've done my staining, in cases in whom I suspect there could be a lax lid and tear problems, I take him to lie him down and look at my fundus, and then I bring him back in, and all this takes about 5 minutes or so. And then again, I look at him on the slit lamp, and if I still see a nice fluorescein stained tear meniscus sitting there, I know that he has a tear stasis. You could, of course, do a fluorescein clearance test if you want to quantify the whole thing. But here we don't really, unless you're doing a study or a research situation, we don't need that kind of data. We just need to know whether the tears are not going off the surface like they should. Because it's not just the quantity of tears, it's also the quality of tears, and it's also the tear turnover process. So if you don't have tears getting turned over on a regular basis, and they tend to collect on the surface, like in tear stasis, they can produce significant symptomatology. It can also give you a nice BUT. So basically, it tells you the stability of the tear film on the corneal surface. And if it's a very short BUT, then you can have a significant symptomatology. And the Japanese are very fond of this. They have actually defined an entity that they apparently see a lot in their patients. They call it the short BUT dry eye. So these are people who have apparently a normal Schirmer. They don't have much staining, spotty staining on the surface, but they complain intensely of symptoms. And when they do the BUT, they find that it's very short, and using some kind of a mucin secreting analog like diclofenac, which they have, allows them to treat the short BUT dry eye. The fluorescein stain also helps us to pick up the health of the surface. So it doesn't matter whether your Schirmer is 12 or 18. The analogy here is like the pressure. You can have nerve damage in somebody who consistently records an 80 or 16, and you can have somebody with a 22 or 23 pressure whose nerves remain healthy, who's the so-called ocular glaucoma suspect. We continue to follow them up. So similarly, if you have a myopic large eye with a large exposed ocular surface, you obviously need a lot more tears to surface that area than if you have very chinky eyes and very narrow palpebral apertures where a small quantum of tears is enough. Be that as it may, no matter what your Schirmer shows you, if you're seeing a lot of staining of the conj and the cornea, then that particular eye is hurting. The tears are not enough. So the fluorescein stain tells you that as well. It can also tell you when there is frictional damage on the surface. So when the tears get reduced, when the lids translate across the ocular surface, there is more friction, and this friction results in various changes. And finally, the staining also helps you to try and distinguish between the aqueous deficit and the evaporative dry eye. So the fluorescein stain, one test, simple test, allows you to pick up the deficit that's happening in the surface in terms of the tears. It tries to tell you what type of deficit you have, and it shows you the effect of this deficit on the surface. Let's look at the next couple of slides, which explain this a little better. So this is the lid Viper Epitheliopathy. So you see the lissamine green staining along the lid Viper, which is this 2 millimeter mucosal area right at the terminal end of the upper palpebral conch. This part has about 90 to 95% contact with the ocular surface when the patient blinks. So if you have tear deficit and there's a lot of frictional damage, then this area will stain. Similarly, if you have somebody with a conjunctivo-calatic fold, which is repeatedly getting trapped between the lids when he blinks because of the loose fold, it will keep getting traumatized repeatedly, and you can pick up this kind of staining. And obviously, patients with this amount of staining will complain bitterly of constant symptoms with almost every blink. And finally, this is the so-called line of marks. I've used the rose bengal to show it here, but you can get the similar staining with the lissamine green as well, or you can get it with the fluorescein as well. So what does this signify? Let's just look at it. So this is a very magnified view of the lower lid margin. So this is the margin that is the posterior margin close to the eye. This is the anterior margin where the lashes are. And these are the openings of the Meibomian glands. So in the normal eye, there is a small bead of oil that comes out of these Meibomian glands. And because of the presence of this yellow oil, the tear meniscus is kept behind it. So the tear meniscus cannot go past the oil. And this is the position of the normal tear meniscus in healthy eye. When you use lissamine, rose bengal, or fluorescein, you will see a line of spotty staining, which reflects the position of the tear meniscus on the lower eyelid. And in a normal eye, with normal amount of oil and healthy tears, it will be roundabout at the level of the Meibomian gland openings. Now imagine, if you will, a patient with a tear deficit in whom the tears have started to shrink. There is less tears, and therefore the meniscus is not healthy anymore. It has started to recede towards the posterior lid margin. So in this case, when you look at the line of marks, this will also follow the tear meniscus, and it will basically stain the junction of the tear meniscus on the lower lid. So this line now recedes posteriorly towards the posterior lid margin. On the other hand, if somebody is starting off with basically a Meibomian gland problem, where the oil secretion is not adequate, there's very little oil, in this case, the tears are able to spill over the border of the Meibomian gland orifices because there's not enough oil to keep them in check. And in this case, when you look at the line of marks, it would have moved anteriorly, mirroring the position of the tear meniscus. In this way, to some extent, we can have some idea as to the aqueous deficiency or the evaporative dry eye state in that particular patient. So since we started talking about Meibomian glands, and since Ruchika wanted this as well, I'll take the next 5 minutes to cover this. We basically know that there are about 25 glands in each lid, little more in the upper lid. They have like vertical toothpaste tubes excreting at the lid margin. There's basically a normal and a mixture of lipids that they produce. We won't go into the details here. And their functions are to slow the evaporation of the aqueous tears by producing that oily film over the tear film, so that between blinks, the tear film evaporation is slowed down. They help you preserve a clear optical surface and, of course, form a barrier to protect the eye. Now, there are various things that can go wrong. So this is a patient with a congenital absence of Meibomian glands. So here, when you do the infrared mammography, you see one distorted Meibomian gland, and there are no glands along the rest of the lid. So obviously, this is a prime candidate for an evaporative dry eye. When you have Meibomian gland dysfunction, basically there is a change in the composition of the oil secreted, and the basic change is an increase in the amount of short-chain fatty acids and triglycerides that are produced. And this is because the bacterial contamination that coexists when there is a lot of oil, the bacteria increase because the oil is a good energy source for the bacteria. They consume the oil that the Meibomian gland is producing. They produce these as basically after they finish eating the oil, this is what they produce, short-chain fatty acids and triglyceride changes. And these are irritating to the eye. And that is why you can get a lot of congestion and inflammation on these people. And obviously, you will have a short BUT if there is not enough oil on the surface. If you get used to looking at normal eyes, again, patients who present to you for cataract surgery who are essentially normal, you flip the lid and you can make out the Meibomian gland architecture very nicely. So you don't really need an infrared mammographer. But if you have access to one, you can see the same thing highlighted even better. And like in that particular patient in whom we had only one distorted gland, if you have a lot of Meibomian gland disease happening over a period of time and there is Meibomian gland dropout, These pictures can also be used, you can analyze them using these little software that they provide. So they will tell you the extent of dropout. The importance of understanding this is that if you're going to use something like the IRPL to try and stimulate the glands and try and get back a better function, you must first have glands on which this treatment can work. So if you have more than 70% dropout of the glands and there's less than 30% functional glands, then it's questionable whether these treatment options will work because there's just not enough glands for them to do their work on. Now, for the physiology of it, this is a device that was provided by Cobb and Blackie. Basically, it's a spring-loaded device which produces a graded amount of pressure on the lower lid. You don't need it. All you need is your thumb. You can put your thumb on the lower lid of the patient's eye after you've done your surface evaluation and put a little firm pressure, not enough to make the patient squeal in pain, but not gently caressing him as well. Just a little firm pressure. Your thumb will usually encompass 3 to 4 Meibomian gland openings. So when you put the pressure, what you want to look for is, one, how many of these gland openings actually have secretions coming out of them? 2, what is the quantum of secretion that is coming? Normally, you should get a very small, clear bead of fluid. If you're getting an excessive outpouring, that is Meibomian seborrhea. Or if third thing is, you look at the quality of the secretion. If it's not a clear secretion, if it's a lot of turbid muck, or if it comes out like a little toothpaste tube, white calcific material, then you know that there is a lot of inflammation in the glands. And like I said, if you want to look at the interferometry, unfortunately, there's no clinical correlate to this. You do need a device to look at the oil on the surface. So like I said, Meibomian seborrhea is one type of dysfunction where you get an excessive outpouring of oil onto the surface, but the oil tends to be relatively clear. You can get Meibomitis, where you get this kind of toothpaste tube kind of, you press it and toothpaste-like material comes out. This is inflammatory. Or you could get the third kind, which is sicca. So you can see that the gland openings are all cicatrized and shut. So here, no matter how hard you push on the lid, very little oil will come out. And here, these are people who will have an evaporative state. So we also look for inflammation along the lid margins. You can see this thing basically thickened. You can see roseolate vessels over there. So this is signs of inflammation. And you can see this kind of Meibomian, pus-like material coming out of the Meibomian glands, or you could get little cysts covering the openings of the glands. And sometimes you can see this froth. This froth is because of the altered quality of the oil, and every time the lid blinks, the oil is getting churned up, and then you will get this kind of frothy discharge along the lid margin. We know about seborrheic blepharitis, where you can see this curve here, and you can also get the staphylococcal blepharitis coinciding, present in association with Meibomian gland dysfunction, where you can see these little collarettes along the base of the lashes. They can have plus disease, which basically is the chalazion. You can have the staph immune infiltrate. All of this is if you don't treat the Meibomian gland dysfunction at the early stage and allow it to evolve to the next stage. And finally, of course, you can see the cylindrical sleeves along the base of the lash if you have Demodex infestation. And this is the short BUT dry eye that I mentioned, that the Japanese are very fond of. And if you don't have enough oil, basically, again, there's an evaporative state, and you can get this kind of coarse staining on the corneal surface. And the inflammatory changes that happen can produce either conjunctival flictanules, or you can get corneal flictanular disease. And here again, if you don't treat it in time, it can even go on to perforation. So coming to the treatment principles, again, we need to understand what we are dealing with. We need to understand the quantum of oil. So if you have seborrhea or if you have sicca, the treatment will obviously vary. We need to know the quality of the oil. Is it inflammatory oil that is being produced? And we need to look for the presence of inflammation on the lid margin as well. If you're basically dealing with a seborrheic condition where there's excess oil that is being produced, we need to control the oil production and get rid of the oil that's stagnating in the lids. So the traditional way to do this is to do a warm compress. Then you do a lid margin scrub to open up the gland openings where you have those caps closing them. And then you do a physical massage using your finger to basically squeeze the oil out. And this is the manual way. Today, you have devices like the Lippy Flow, where all of this is done automatically. You do the warming, you do the lid compression, and the massaging is done. And this will also do the same thing. It's a more expensive way of doing it. If you have a deficit, if the glands are cicatrized, the openings, there's not enough oil coming off, you have these Masket probes, which are very fine stainless steel probes, which can be introduced into the gland, kind of like dilating the lacrimal punctum, to see whether this will help you increase the quantum of oil that is coming out. In some of these people with ectodermal dysplasia and other changes, you get this bad oil. So these people you can even take to the OR once in 6 months or a year, because these are often children. And you can do this kind of a compression and empty all this muck out of the glands, and then start your treatment to modulate the quality of the oil that will next get produced. And if you keep doing this on and off, you can bring to some extent these people under control as well. And sometimes there have been reports of basically saying that the normal oil that needs to get squeezed out is because of the lid tension when you blink. And if you have very lax lids, this won't happen. So you can do a surgery to increase the horizontal lid tension, although I don't know of anybody who does that. For quality of the Meibomian gland, we use azithromycin. We can use doxycycline, azithromycin topically, doxycycline orally, and omega-3 fatty acids. There's a lot of controversy over those, but in the final analysis, they might help a little bit. So in the really severe cases, I still use them. I don't use them routinely though. So this is the medications that you can use. The other way of doing it is what we'll probably discuss a little more after the last few slides, is the Irpl method, where we're using a light-based approach to try and stimulate the glands to produce a better quality oil. For the inflammation, we can use steroids, we can use tear substitutes to take the muck out of the eye, and you can use cyclosporine if you like. So this is how it starts, the inflammation, the staph immune process, early vascularization, then you get the staph infiltrates on the surface. And if you don't treat them adequately in time, you can get this kind of scars, and sometimes there can even be perforation. For chalasia, basically you can try injections. So you can try injections of 5-fluorouracil, you can try injections of triamcinolone, or you could do your traditional chalazion removal surgically. We use the Himalaya herbal shampoo for Demodex. It contains 5% tea tree oil. Find that quite effective for these patients. And if you have keratinization, which is only in the real bad cases like Stevens-Johnson, so it really doesn't form part of the stock, it's just here for completion. You have to treat the basic condition, but sometimes you can try and use vitamin A ointment to try and modulate this as well. So I think last slide, Meibomian gland dysfunction, it's a common entity in brown skinned races like Indians. There are different types, like I said, seborrhea, inflammatory Meibomian disease, and Zika. We need to recognize which one we are dealing with and have some understanding of the pathophysiology so that you can then try medical management before you go on to procedures. So if you really want to put it all together, this is a composite slide that I do like. You look at the BUT, you look at the Schirmer, you look at the lipid level. So these are the three parameters that you have. Now you have to decide which of these is abnormal, and based on that, you can call it either a preclinical aqueous deficiency, a preclinical evaporative dry eye, or both preclinical. Or it could go on to the frank stage where you have aqueous deficiency, evaporative, or both. Or you could have a short BUT dry eye. But apart from the tear meniscus and its components, do look for inflammation on the ocular surface. Do look for staining, which tells you finally what effect this problem is having on the ocular surface. And like I said, look at the other conditions, zoom out and look at everything else that's happening on the surface. And this is just a composite slide of the various things that can go wrong on the ocular surface, which we need to identify and manage while we are managing the tear deficit in order to get the patient to feel happy and for the condition to get better. So I think I did take a little bit more than my time. I did warn Ruchika that it's a difficult topic to cover in 15 minutes. So I apologize if I spoke too much, but I think this is kind of what I wanted to say. And if there's, now we can, take any specific issues that are bothering people and try and answer those.
It's always a pleasure to hear you speak. So even if you exceed or take the entire 1 hour, it's not at all a problem. And thank you for this very, very lucid talk, and especially highlighting on the fundamentals, which many times we tend to overlook or forget, like just looking at the patient as a whole, the lids, the conjunctiva and everything. So does anyone have any questions? You can just put it on the chat box or unmute yourself and ask if anyone has any questions in particular.
I really enjoyed it. So, time flew by and it was like a masterclass. Really enjoyed each part of each slide of this talk, sir. And, I just had one small question. We do use the machine quite often, and, we try to understand a few things, and it works well for us to, especially, and realize that in some patients, they're not convinced that they have a situation, and it helps to explain to them, because you have already seen what you want to see, but getting it more objectively. All the same, I do notice that there is you will probably not end up doing these tests yourself on the machine, because in a busy clinic I've seen inter-operator, kind of variation. So sometimes I feel whether it's really objective. Few things would be objective and few things aren't. So sometimes I get a bit this thing, and a couple of times it's happened that I've tried to have the test repeated and then found there was a vast difference in what we got in the first go and what we got. So that thing troubles me a little bit about this. And maybe if you have only one person doing this all the time, then might make more sense than having 2 or 3 people, doing this in between. So I think quality control is very, very important. And but on the other hand, it has made us recognize the entity much better, and we've been able to kind of understand it so much better. And patients are also more convinced that they actually need treatment. Today, sir, I had one patient whom, in fact, today only, who kept complaining that I've visited many specialists, and he was carrying a whole, bunch of papers, and he had been treated for dry eye disease in various ways with minimal MGD, but mostly he had, everything was almost normal, including his shamas. All his complaint was that I keep getting burning sensation in my eyes all the time. He did not have allergy that I could see. He did not have any significant MGD, which was remarkable. Yet, and all his tests were normal. I mean, I did the on the SBM, and we found that. So I was today I was perplexed because most often I will find something and I'll have something to treat. Today I didn't have anything to treat, and yet his complaints were very, very clear that he suddenly gets. In fact, the attendant said that sometimes he's just talking and he'll suddenly get significant, and it wasn't like a blepharospasm or anything like that. It was more just a burning sensation. I refracted him. He had almost no acceptance. I thought he may be a subtle hyperope or something, and that didn't come out either. It was about a 40-year-old gentleman. And again, I tried to look for presbyopia. He did not have any yet, so I was just thinking that, I mean, since it was an interesting one, and I thought today I should ask you when I see you that what else can I do for this patient? He's going to come back to me in 15 days. If I put him on, one lubricant and reassured him and given him some lid massage and, hot fermentation just to see if it works.
I think you put it in the nutshell. These devices basically are useful, but they have limitations. So I don't think we should get too dependent on them and get into the habit of just sending the patient for a test, bringing it in and just making something. I think it's very important, like I keep saying, at the risk of repeating myself, is like you said, you first evaluate everything yourself. You get a clear handle on what's going on, and then this just serves to confirm those things and maybe document it in a more quantitative manner or a semi-quantitative manner. And like you said, you can put that sheet in your case sheet, and later on you can, then more importantly, it helps you to, it's like having the OCT in somebody with CME and showing the patient that and showing him, look, these are the cysts, this is the other eye, you can see the normal retina. It helps the patient to understand and maybe quote unquote convince him about what's going on. So from that perspective, yes, these tests are useful. Again, apart from the observer, the person who's doing the investigation, like you said, it helps if you have only one person or two people who are used to doing it again, rather than everybody just walking in and trying to take the test. I think the time in the examination when we do the test is also important. Usually for us, if I have a significant ocular surface problem, by the time they come to me, they've already gone through the initial workup, like I'm sure it happens with you. So we often call them back again when the surface is virgin to do all the evaluation. So if they've already had a 1.5 hour, 2 hour stay in the clinic, they've had AT done, they've had anesthetic put in the eye, dilating drops put in the eye, then I think it's probably kind of not very good to do all your sophisticated measurements at that point in time. They may be variable and so on and so forth. So that's the second thing. Now, this third patient of yours, the burning patient, I think there are two angles from what I will see. Since you have seen him thoroughly, I don't think it's a lid viper or a superior limbic. These are two conditions in whom burning is the most important symptom and in whom tear substitutes don't provide relief. Because this is an inflammatory component to this, these are the people who will do well with steroids. But you also mentioned that this person has it episodically. He's been sitting and talking to you, suddenly he gets a bunch of burning. So in this situation, for me, this would be trigeminal more than anything else. So like a trigeminal neuralgia. So again, when we talk about the nerves, we talk about neurogenic pain and neuropathic pain. Neurogenic pain is pain that is quote unquote normal pain. So if you take a pin and poke my hand, I'm going to scream in pain. So that is neurogenic pain. I've stimulated my nerve. If you have somebody in whom a puff of air on the eye produces significant burning and pain, that is neuropathic pain, where the nerve is reacting in an abnormal manner to what is technically normal stimulation. So here again, there could be an abnormal firing of the trigeminal nerve and so on. So in these patients, it is my practice to not commit to anything right in the beginning. I don't give them any treatment measures telling them, I think this will make you better. I tell them that I think that your problem is outside the surface because I've done everything. I don't find any staining. I find a tear film which is normal. I don't find a BUT which is abnormal. I don't find any changes. So I don't think this is related to the ocular surface. I'm giving you something. You probably already tried it because you said multiple people have seen it. So we can try this, but if it's not better, I may request a neurologist or a physician to see you right in the first visit. I tell him that. Because otherwise, what happens? I give him treatment. He goes, comes back 2 weeks later. He's sitting there with a very accusing look on his face, saying, "I did everything you said. I'm not better." Because he's already been through 4 or 5 doctors, so he's already frustrated and irritated. So I don't make an error of commission here. It's better to do an error of omission. So I tell him point blank that I don't think this is your surface. I'm giving you something. Last resort, if it doesn't work, I'm going to send you somewhere. So when he comes next time, he comes with the mindset, "Oh, I'm not better, so the doctor's going to send me somewhere." So I don't try and, so that is my fail safe. I leave myself a escape route.
I agree, sir. Thank you so much for that, sir. Also, one quick question, because I see a lot of questions coming up from the audience, from our other attendees also. So I won't, disturb, but is it standard of care today to be doing something like the SBM kind of a test for all our pre-refractive surgery and cataract surgery patients?
Just this evening when I was driving back home, I was having a chat with my son who's just finished his ophthalmic training and who's joined me. So we were talking about this, we saw a patient from somewhere else today, and he basically had a pre-cataract workup, which had an OCT, which had a specular and this and that. So we were just casually talking. I said, look, as a corneal surgeon, if I'm going to get a specular done for all of my cataract patients, just as a, fade, I think it doesn't make any sense. I shouldn't be calling myself a corneal surgeon. It doesn't mean I don't do speculars for my pre-cataract patients, but I think that I should be, able to pick up corneal changes significant enough to affect the outcome of cataract surgery without a test. So similarly with the OCT as well. So I think the question you're asking is something similar to that. I think if you want to be absolutely safe, I guess you could. But if you do find a change in that, then that's going to delay your surgery by another month or so. So for me, finally, even for a refractive surgery patient, my final test is the stain. I do the stain. If I see any staining on the surface, then I will go through the whole rigmarole and blah, blah, blah. If I don't see any staining on the surface, then I don't really honestly care. It doesn't matter as long as I don't have frank lid margin infection. If the lid look a little oily or something, it doesn't really matter. I will go ahead and take care of the patient. So, but this is the old-fashioned way of doing it. I'm a dinosaur.
I completely agree, sir, because we don't do it as well. We would select our patients where we need to kind of work them up, but not every patient will get it. But this is what I keep hearing from many of my colleagues, that, we are doing this as a routine. And frankly, we don't end up charging our patients for all these things. For example, refractive surgery workup, we nowadays do an eye trace, we do an epithelium mapping for all of them. We don't end up charging for it at all. I mean, we just have a small package of maybe 1,500 or 2,000 in which we do a pentacam and
everything comes in. Agree.
Right.
This is exactly what I was telling him, because he comes from an institute where he did his fellowship. So he said this is standard of care. So he says instead of charging the full amount for the test, they have a package and everything is done. So I told him again that it doesn't matter whether you're charging the full rate of 2.5 or whether you're charging 500. My question would be, is that test indicated at all or not?
It also slows
if you're
down.
Doing all of this, like you're saying, I do it free for everybody because I want to be 100% sure that the cornea is healthy, that the macula is perfect, and I don't charge him for it, then I have no objections at all. You can do every single test under the sun. But when I'm charging my patient for a test which I think is not necessary, then I have questions about it. But again, I told him I'm not commenting on the other practice. It's just that I wouldn't be comfortable doing it, and I've never done it, and I don't see myself doing it. And I think that would answer your question about the SBM as well. Absolutely. I don't do it routinely for everybody unless I suspect a particular component. Then of course, yes, we do it. So
I think I'll pass on to Ruchika now to take it forward. Yeah, she has.
So yeah, sir, I have a few questions. Like, if you do find on clinical examination some of your patients preoperatively for cataract or refractive are candidates for the IRPL, how long before surgery would you like to do it? Like, I mean, the time interval between planning the treatment and going ahead with surgery, what is the interval that you usually like to keep?
The treatment itself, the recommended scheduling is day 0, day 2 weeks, and day 6 weeks. So having started the process, ideally you would like to complete it. So that would be a 6-week period. And during that period, we also will add on some lid massage and hygiene measures, because the IRPL only modulates the quality of the oil that is produced. If you have a problem with the excess oil, then that has to be physically massaged. So these are not two, they're two independent options basically. So he would do that as well for the first 2 or 3 weeks, and then there's a 6-week course for the IRPL. So by the time he completes the course, he will be ready for the surgery, provided the clinical evaluation is satisfactory.
And sir, like their recommended schedule is at least 3 sittings. Now, since you've been
Yes.
using the machine for some time now, sir, do you insist on 3 settings? Like, do you see a difference or a change in the patient symptomatically only after they complete the 3 sittings, or sometimes are they okay even with 2 sittings? Because a major problem with us is that we have a lot of our patients coming from higher altitudes who are not able to follow up with this, the 3 sitting course of day 0, 2 weeks, and then 4 weeks later. So is it okay to just end at 2 sittings, or do they actually need to go through all the 3 sittings?
I think the answer honestly is I don't know. The studies have shown that you need 3 sittings, particularly if you want the prolonged relief for at least a year. I have both categories of patients. I have patients who see me. I normally see my patients after the second sitting. After they do the second sitting, I see them once before they go on to the third sitting. And usually they tell me that they're feeling about 60 to 70% better by the time the second sitting is over. And when I see them again a month later after the third sitting, they tell me that 90% of their symptoms have cleared. They feel much better. But I've also had a few patients who've done only 2 sittings, and they, for some reason, like you said, couldn't have the third one, and they come back 6 months or so later, and they do say that they have had some benefit. Again, this is a condition that can't be really quantified in mathematical terms. A lot of it is subjective as well. So the same patient who's gone back to a very busy schedule on his computer will not feel so much. With another elderly patient who's not working with the computer at all, he'll already feel better. So there are multiple other factors that come into the play. So I would still think that if we can do the 3 sittings, I would prefer to do the 3. In fact, I tell my patients that when they schedule it, I ask them to lock down all the 3 dates, make sure that they're not traveling or they're in town on those 3 days, and only then start the process. Because I think the treatment is fairly time specific. So we allow 3 days this way or that way from the date that we've chosen. But I don't want them to do it 2 weeks and then come back instead of 1 month later, come back 3 months later and say, now I'll have my third sitting. We tell them we're not sure if that will really help you at all if you do it that way.
Also, sir, amongst the many contraindications for doing an IPRL is one is avoiding these photosensitive drugs. So most of our MGD patients are on doxycycline. So is it really important? Do you make sure that they are off these drugs?
No. In fact, I basically start them on doxycycline at the same time that I start the IRPL. The photosensitivity issue is only on the evening of the day of treatment. When they go out, they shouldn't expose themselves to too much of light. Here again, because it's all periocular, if they have a pair of shades, that's pretty nice, although they don't want to go out and play cricket after getting IRPL done in the sun. But right after the next day, it doesn't really matter. So the only thing you really need to be careful about is the grade of skin pigmentation. If it's really dark skin, and I don't think we are talking about the African Americans and so on, that kind of dark skin. Indian skin, like I'm not very fair. So we have patients who have my skin tone in Chennai all the time or a little darker. We've had no problems doing it in those people. And to answer your specific question about doxy, no problems at all. In fact, the day they start the IRPL, they also start the lid cleaning and massage and all that. And along with that, they take a 10-day course of doxy. This has been standard for me right from day one. We've not had any problems with that. I think there's some questions on the chat. Yeah.
Right.
If you're
So
taking them, that's fine. Yes.
So there's a question from one of our pediatric specialists. So she's asking if you have seen dry eye in pediatric patients, especially after the COVID pandemic.
Not particularly. I'm seeing it. They're complaining of symptoms. So I think we have to be clear about symptoms versus dry eye. These are children who are now doing a lot of online stuff. And as it is, they're all playing on video terminals all the time. My younger sons, I can't separate them from their phones. It's like it's there. So they're eating with the phone. It's there all the time. So they naturally complain of symptoms. So that doesn't necessarily mean dry eye. Dry eye in pediatric population is extremely rare. The child's eye is a very healthy system. It can take a lot of abuse. So for me, dry eye in a child means there is a problem. So basically, there is some cicatricial conjunctival disease, or they've had a Stevens-Johnson, or they've had a graft versus host, or something like that. And a normal child cannot have dryness on the eye. That's my dictum. So they can complain of symptoms, and that's because they're staring at screens in an AC room without blinking, blah, blah, blah. So those can be managed. But I don't think that's why I said we have to distinguish between symptoms of dry eye disease and actual dry eye disease. We should not club the two together. The children and dryness in terms of staining and this and that, pathology. It cannot be normal.
There's a question from Dr. Saurabh. He's asked for patients who've undergone long VR surgeries with hydrogenic epithelial defect, what should be the ideal treatment modality?
Basically, I would presume that a bunch of these people would also be diabetic. So basically, they have the basement membrane issues and healing issues. So while you're removing it, I would be very gentle in removing it. You can use the hockey stick knife or whatever, but it's very important to keep it parallel to the surface and not incline it, because if you damage the basement membrane, then it's going to take a long time to heal. Whereas if you remove it gently, generally it should heal very quickly. A normal eye with a healthy limbus will heal a total epithelial defect in a maximum of 24 to 36 or maximum 48 hours. Otherwise, we won't be doing PRKs. Otherwise, we won't be doing collagen cross-linkings where we remove the epithelium with gay abandon. So here, I don't think you need to worry too much about it. So basically, just put them on any lubricant which has a gentle preservative. If you have access to unpreserved tears, it's even better. You will be putting some medicines on the eye anyway after your surgery, some antibiotics, some steroids, and maybe some cycloplegics. Those are fine, I guess. Yeah, I think you should start pushing warning buttons if it does not heal after 5 to 7 days. If you have a defect that is not healing after 5 to 7 days, then there are issues. So either there's a limbal stem cell deficit, there's a neurotrophic issue, or the medicines you're using other than tear substitutes are causing some toxicity, or there's some underlying basement membrane damage. In this situation, then basically send it to Ruchika. She'll probably put a BCL on, will possibly put punctal plugs in to try and increase the natural tears. And if all of this doesn't work, finally, in this situation, we can use autoserum as well for a little bit to see if we can get some biotrophic substances in to get it to heal. But having been in SN and having seen these people come in again and again, usually they don't cause much of a problem. As long as they don't get infected, they will heal. Just give it a little time. They will.
Thank you, sir. And sir, between Pantogel and hyaluronate, any preference for any of these drugs, or a milder one will do?
Hyaluronate basically is a well-proven product. Basically, we have international studies, particularly from the Japanese, which show that it has epithelial healing properties. So that, I think there's no doubt you can use it. You can use it. Pantogel is being used more from the theoretical basis. I'm not aware of too many good studies which show how important that is. But Pantogel is usually used once at night, in addition to the tear substitutes that you're using during the day. So you can even combine both. You could use your hyaluronate 4 to 5 times during the day and use your Pantogel at night, because you do need some lubrication, because it's a healing epithelial surface which is not very robust. So at night when they sleep, when the lids tend to be in close proximity to the lid, in the morning when they awaken, there can be some shearing forces. So it's always good to have an ointment or a gel on the surface to allow a more gentle separation. The only point of thing with hyaluronate is because it has this ability to retain stuff on the surface for a very long time. Ideally, you shouldn't be using it more than 4 or 5 times a day. Otherwise, if there's any noxious stuff on the surface, that tends to get retained on the surface longer as well. So unlike, for instance, a carboxymethyl cellulose based drop where you can even use it every hourly if you like, which because it keeps getting excreted off the surface rather easily. Hyaluronate is generally used not more than 4 or 5 times a day. That's the only point to remember.
Thank you, sir.
There's one here
Sir.
about patients who don't, sorry, go ahead.
No, sir, please.
I was just going to the first question on the thing. Basically, the patients who don't present with symptoms, but on examination are found to have signs for foamy discharge, should we treat them minimally or investigate them fully and then treat? This is a very difficult question to answer. It depends on the kind of patient, because there are some people where, if you tell them they have a problem and they came in thinking they were all right, it creates a lot of panic and so on and so forth. So just a little foam on the lid margin, unless it is excessive, unless I'm seeing the congestion and that inferior corneal vascularization that I showed you, where I think there's an early staph immune process building, then I cannot sit back. Then I will tell the patient, yes, there is a problem. You may not be aware of it, but if we don't head it off now, we can go on to more severe problems. And then I will go through the full regime of Meibomian dysfunction treatment. But if it's a very healthy surface, no congestion, no inflammation, no corneal vascularization, no staining, if there's just a little foam, I brush it under the carpet. I won't tell the patient. Because if you tell him he has a problem when he comes in thinking he doesn't have any, then basically you are basically waking up a sleeping devil. So I generally leave him alone and just keep following up when he comes back. Any pre-op measures to be taken to prevent or minimize dry eye and cataract surgery patients? I think I will let Gaurav answer that, because this has been a fascinating question for me, because I, unlike many of the young ones, unlike Ruchika and all that, I started my training doing ICCEs at SN, right? So we used to do 12 to 14 millimeter incisions, do a large conjunctival peritomy, use that diathermy. We didn't have wet field cautery, so we used to have a diathermy, and I used to use that with gay abandon, because I didn't want a single bleeding spot before I made my incision. And then I used to create 12 to 14 millimeter incision. Then I would put in something like 7, 8, 9 sutures. And the funny thing is, the patients never complained about dry eye. We never spoke about dry eye. Now I'm doing a 2.2 millimeter incision and maybe 2 sub 1 millimeter incisions, sometimes only one of those as well. And now in this situation, I'm hearing a lot about dry eye, and I'm talking about what should I do before surgery, during surgery, after surgery. So I'm quite very interested to hear what Gaurav has to say about this.
So in fact, you took away what I was thinking about. I often think about that, when the first lubricant became available, I was doing my post-graduation, and they said, oh, there is something known as a tear substitute, like artificial tears. Eye drops were launched by, I think, Sunways or somebody. I don't know. I don't remember which one would be the first one which became available, but that's when I remember Professor A.K. Gupta telling, and Dr. Ritu Arora, and they were both my teachers, and they said, we'll start using this and see how it works. And before that, all we used to rise was 20% sulfacetamide for every patient, and probably producing a lot of dry eye as well. But from there, and I agree that, we used to do intracapsulars exactly, and, enjoy doing those thermal cauteries with the Bowmans and, take away every bleeder. But frankly, today, when I see patients, I think what I'm looking for, I'm not probably going to start all my cataract patients on some kind of measures. Yet there will be patients who will, obviously have situations which need to be tackled before you can actually take them. So significant MGD or tear film dysfunctions, I would obviously, defer their surgery rather than jump and operate upon them, because they are the ones who will probably come back with issues to you. So I would give them a week or 2 or 3 or even more. And treat them, and they are actually very thankful, and you notice the difference. It's not just the cataract patients, even some of the refractive surgery patients, I noticed, and Ruchika and me typically call them back after 15 days, put them on treatment. What I would like to hear from you, sir, in addition to what we are doing, is any role of things like cyclosporin drops or something else beyond the ordinary for some of these patients, and also some of our refractive surgery patients where, is there a role? I keep reading Caranet, and I keep reading other places where, they start patients on restasis before they actually go ahead with surgery, maintain them for like 15 days or a month. Does it actually work for these short periods? Because what my conventional thought is that what we were taught is that it should not be working in such short periods anyway. So putting them on 1 week of cyclosporin before you operate, I don't know. I thought this is one thing which I want to ask you.
I think it's an important question, this treating the, I think it also is to do with the kind of surgery we are doing today, the expectations that we have engineered in our patients and so on and so forth. I used to have an ambassador long ago So in an ambassador, squeaks and creaks are the norm. If you don't hear it, you're wondering car's not working. So you will hear. But today, when you buy your 35, 40, 50 lakh cars, and then even a small squeak upsets you, you want to take it back and say, BMW guy, come and there's a squeak, replace something. So I think that's where we are with surgery today. We've taken care of most of their problems. There with the ICC, first you didn't want infection, then you wanted the wound to heal, then you didn't want vitreous, then you wanted a quiet eye. So other things took precedence. So probably the dryness and all didn't really matter. Now with phaco surgery, they want to see 6/6 the next day. You're putting in a multifocal, you're putting in a trifocal, you're putting in something. So basically they want to see everywhere from there to here. So now small things become an issue, and it's also important to address them, I guess, because if you promise them all this and if they're paying a fat amount of money for all this, then I guess it is fair to take care of it. So, but I don't think we need to necessarily put every single patient on tear substitutes during, before, or after surgery. Like you said, if you have a problem, of course, you take care of it before you address the surgery, both for refractive as well as for cataract. But I don't write tear substitutes for everybody just because I'm doing a cataract for him. So, and again, the restasis, like I said, in my opinion, I think it takes about a month or 3 to even bring in its effects. It's a cumulative thing. It acts very slowly. So if you're going to do it, you probably have to do it properly. Just putting it for a week before a refractive procedure, in my opinion, is probably pointless. I think it's just a placebo thing. Makes you feel better, I guess, but I don't think it really does anything for the patient. So that's how I would look at in this context. So, and particularly if you're doing topical and if you're doing gentle surgery, and most phacos today take 10 to 12 minutes, so microscope light, everything has become secondary. So I think some of it also has to do with marketing. If you have a product, then you have to have a need for the product. So sometimes, the product creates the need, or it is created. There are multiple factors at play here. So purely on a scientific basis or a platform, I personally find it hard to justify tear substitutes in every cataract surgery. And I'm scared to prescribe it after surgery, because when I'm prescribing like an antibiotic, and I'm prescribing a steroid, and I'm prescribing sometimes an NSAID in a diabetic and a tear substitute, I worry that he will stop the steroid and use the tear substitute 6 times. The more you give, the more the chance for errors. So I won't use it. And anyway, if he's anyway using a steroid 6 times a day for the first week, and then 4, 3, 2, 1, he's got moisture on his eye. It still tears. I mean, it still drops. So I don't think you need to add a separate tear substitute in a normal cataract. Maybe after a month or so, if you take tail off these and then he's complaining of irritation, adding a tear substitute on a case-by-case basis may make some sense, I guess. But this is my view. I mean, it's not necessarily the only correct view. Or I'm sure there are a lot of people prescribing it, and I have nothing to make, no objections to that as well.
Thank you, sir. And so, since our meeting was, focused on we were trying to understand, in fact, the core purpose of today's meeting, and we've learned so much today beyond what we thought we would. But for the IPL therapy, which are the ideal cases that we should be looking for in our practice every day? Because, we've had the machine for a demo for 2 months. We've hardly done about 8 or 10 cases, because one reason was what Dr. Ruchika said, that, sometimes these patients say that we won't be able to come for follow-up. So we've been reluctant to even give them the first one. And the second reason is that, I would love to, Ruchika has better understanding than me, but I would love to hear from you, like, which are those patients which will really benefit, and which are those who are sitting on the fence, like where you may or may not see something.
Yeah, I think it's a good question. To answer the numbers, basically we do maybe 2 or 3 a month. We've been having it now for, I think, close to, Icha will probably know better, maybe a year and a half or 2 now, probably 2 to 4 patients a month. And I don't think it has anything to do with the COVID pandemic and lesser numbers attending the clinic and all that. Because I think for me, there are 2 categories of patients in whom I will use it. One is somebody who comes to me with significant symptomatology, in whom I'm convinced there is a Meibomian gland dysfunction at work, in whom I put him through my usual 3-week course of lid cleaning, lid massage, and my usual combination of tear substitutes, a soft steroid for 2 weeks because he's massaging all the oil out into the eye. And they get a 10-day course of doxy and maybe a 3-week course of omega-3 fatty acids. So at the end of 3 weeks, if he's feeling partially better or largely better, and if I see improvement on the surface, that's where we stop. At most, we may continue the same lid cleaning hygiene for a little bit longer and then stop. If I've done this and he feels marginally better, but comes back within the next 3 or 4 weeks with similar aggravated symptoms, or if he says that this lid cleaning stuff has made no difference to me at all, then we move on to the IRPL. The second category of people is people in whom I've been seeing for a while our presence for the first time, in whom I've already had episodes of staph immune keratitis and corneal damage that has started. Those little opacities in the inferior cornea that I showed you. I've had children who've had basically significant corneal damage from untreated or partially treated or improperly treated lid margin disease. So in these people, while I institute my therapy, then I will also simultaneously start the IRPL because I cannot have the cornea being affected from a lid margin disease. So these are the two categories in which we use it. And like I said, it boils down to about, for our small volume practice, about 2 to 4 people in a month. So it's not something that you would be doing tons of patients on, or everybody who has the slightest froth goes on gets an IRPL. I don't think so.
Thank you so much.
So I just have a small point, if I'm permitted.
Yes,
Can I
yes,
say,
please.
sir, or shall I wait?
No, please go ahead.
Yeah, thank you. Thank you very much, sir. I just observed the number of treatments is being used. The machine you have been using it almost now 2 years plus, sir, and maybe close to 3 years, we can say. And the averaging is close to around 9 to 10 treatments is now happening, sir, from our center. From your center, sorry.
Per month, you mean?
Yep.
Yeah, that is because you have day 0, day 2, weeks,
Yeah,
and 6
yes,
weeks.
yes.
I'm talking about
Yes.
the number of patients.
Patients, yeah. Number of patients, yeah.
So each patient translates to 3 treatments.
Three
So
treatments.
that is how, yeah, that's what I'm saying. That's exactly right. So if I say 3 patients, that comes to 9 treatments per month. Yeah, you're right. You're talking treatments, I'm talking patients.
No, thanks. This is a good eye opener for me. So this way I've never analyzed it, but that's a good thing for me, sir. Thanks for that. Thanks for the opportunity.
Today, sir, I was reading one interesting thing which I forwarded to Dr. Ruchika also about somebody, in the US. I don't know which doctor it was, Priya Gupta, I think. Yeah, she was talking about using this thing, intermittent pulse light therapy for chalasia. So, is there a role there, and if at all,
I'm not really sure. If I have, for a primary chalasia, obviously not. If you have recurrent chalasia, I would be more inclined to first use Demodex-based treatment. And then if it still persists, then obviously treat, because in a chalasia, while I treat the primary lesion that they come to me with, the moment 3-4 days after the incision or whatever I've done, once it gets better, we put them on the Meibomian dysfunction treatment as well. Because it happened because of the Meibomian dysfunction. And while I've taken care of that particular episode, I don't want subsequent episodes to keep troubling the patient. And then that goes down the IRPL line. If I've done the treatment and I find after 3 weeks, I don't find the relief that I want, or the glands still look mucky, then of course they will go on. But would I take a chalasia? In fact, I think if I have a chalasion, I actually defer the IRPL until I fix the chalasion. I'm not really sure how it works in the context of a chalasion. I don't think there's any data on that. But if I have recurrent chalasia, then for me, my primary option would be to look for the Demodex and then try and put them on management of Demodex as well, and then move on to the IRPL if the lid margin disease is that bad.
I don't know if anybody else. We have Dr. Rajesh Tiwari. He's one of our guest surgeons today. He's a senior. Dr. Tiwari, do you have? He's a very good academician also. I don't know if he has any questions. He's, I can see him, but he's more of a listener. Sir, anybody else?
There's one last question here, which I will also take before, if you want to close. I think this is about which kind of lubricating agent should we use for a general ophthalmologist. Thank you. So I don't think there's a perfect answer to that question, but I think for me, my go-to drug is a carboxymethyl cellulose-based drop. Basically because it comes with a nice gentle preservative. So particularly when you're using a drop more than 4 to 6 times a day, do pay attention to the preservative. It comes as 0.5% and 1%. Usually you prefer the 0.5% because it has less blurring. The 1% is for people with more significant dry eye. If you see a very short BUT, if you have surfacing issues on the cornea, then I use a HP guar based drop because it has a mucomimetic effect and it tries to hold on to the tears on the surface a bit longer. And if I have an epithelial defect, like Dr. Saurav was asking, and I actually need a drop that has epithelial healing properties, then I go to a hyaluronate-based drop. So very crudely, these are my yardsticks for which one I will use. So I use all 3. I have no single preference. I'm not mentioning any manufacturers, but I'm mentioning the product that they contain, ingredient. So this is how I try and distinguish between the 3.
Wonderful. Thank you so much. Anything else, Dr. Ruchika? Do we want to trouble sir for 2 more minutes for anything else? Dr.
No, sir,
Tiwari?
just one a very small question, sir. After your the IRPL sittings, do you express the mebum, or do you just ask the patients to continue with their regular
That's
massages?
an interesting question. See, I think it depends on the severity of the problem. And like I said, I use the IRPL only in people who have a significant level of severity. So what I have started to do in the recent past now is when we start the IRPL, they also start a 3-week course of lid massage. So in my opinion, the IRPL modulates the quality of the oil. And these people also have a quantum issue. So we need to get rid of the excess oil as well. So they do both simultaneously. And after the 6-week course, what I've started learning to do is for the first 7 days of the month, for the next 3 months, they do this lid cleaning and a little bit of mop up. So instead of just doing one stretch and then absolutely stopping, I try and taper it off. So instead of having them go through this stuff, it's very tiring for them as well. So they will do it on day 1 to day 7 of the next 3 months. So for instance, Jan, Feb, March, if they finish their course of IRPL sometime in mid-December, for the next 3 months, for 1 week, they do this lid cleansing and all that with a little doxy for 5 days. And the lubricants, of course, they keep continuing. And when they do the massage for that week, they will use a soft steroid twice a day for 3 days, once a day for 4 days, just to take away the inflammation. And after 3 months, when they come back and see me for the final visit, I think I have things under good control. Then they go away and come back after a year. So this is something I've started doing in the recent past. It's working out quite well, although there are no studies or any data to support this. But anecdotally, I can tell you that instead of doing everything in one shot and then absolutely stopping and waiting for a year, I think this is a nice tapering down, and then it keeps them under good control.
But sir, immediately after the sitting, do you do it? Like soon after?
They do it simultaneously. So let's say I see somebody today in the clinic, I've explained to them about the problem in the IRPL, and they say, good, I'll get it done next 2 days or so, the first sitting. They simultaneously start the lid cleansing process from tonight or whatever, the whole protocol, go through the IRPL, and while they're doing it, they continue to do this as well. So 3 weeks of that.
Do we have any other questions?
I think if Dr. Tiwari, unless he has anything, he's just joined. So, I mean, he's been there right from the beginning, but sir, you are muted. Dr. Tiwari, you are muted. Yeah.
Can you hear me now?
Yes.
Yes, sir.
Do you have any experience of using oil preparation in lipid layer deficiency cases like desi ghee?
No, sir. Sorry, no. Castor oil, that's what in South India, at least, that's the tradition for newborn babies. We put castor oil in the eye. This is a grandmother's remedy from ages. So in these severe dry eyes, when I'm using Restasis, it contains the castor oil. So that gives me some oil. And I think there's a product coming out soon. Alcon is producing something, one version of Stain, which they intend to bring out sometime during the middle of this year, which will contain also the oil, the nano emulsions of oil particles. I think they're calling it Stain Complete. So that's the next in the lineup after hydration. So when that comes in, we will have a product that also provides oil to the ocular surface.
All right. And another question is that do you have any experience of injecting antibiotic into the Meibomian gland itself? Because I read in some journal.
I personally have not done that, sir. I've basically had I don't even do the probing, but in the US, that's become a fad now, probing with the Masket probe. They have a series of fine needles of, very fine gauge. So they keep probing the openings if they're very tight and close, see whether they can get the glands to produce some oil onto the surface. But I have no personal experience with antibiotics in the glands, sir.
And then have you seen tear deficiency in the girls using kajal and openings of the Meibomian gland getting blocked and infected because of kajal?
It can worsen existing Meibomian gland disease. So when we start talking about this and treating this, the next question they sometimes ask is, can I use eye makeup? I tell them they can, provided they spend some time at night cleaning it off. So which many of them apparently don't do. So they can apply it, provided they're willing to remove it at the end of the day. If they can do that, then I guess it's okay to use. But if they're just going to leave it because like you said, the oil and the particles in the mascara mix and they form a little plug, and that closes the gland. And if the gland cannot secrete, there's back pressure when it dilates, and that puts pressure on the ductules, which then go into atrophy, and that leads to gland dropout. So yes, if they are not going to clean it, then they shouldn't be using it.
Thank you. Thank you very much, sir.
Thank you
Thank
so
you,
much.
sir.
I think we've taken so much of your time, and we are really grateful for you to have spared this. But it was really a revision for me and lots of new things to learn. And I think Saurav will give the formal vote of thanks.
So I wanted to thank SKR sir for the wonderful lecture and all the interaction. And I just wanted to say that 20 years have passed, but we still remain in awe. So
Okay. Thank you. Bye-bye.
20 years since fellowship, but you are as impressive and as you were at that time. And I also thank My Healthscape for kind of arranging this, and I thank all the doctors for joining in. And thank you so much, sir, once again. Stay safe.
Thank you very much for having me, and have a wonderful rest of the week and a healthy year to come with the new variants coming in. So be safe, everybody. Thank you very much for having me. Good night. Good night.
Thank you very
Thank
much,
you so
Dr.
much, sir.
From also. Nice meeting you
Good
all.
night.
Thank you very much. I
Thank
just
you
wanted
so
to
much,
say
sir.
thanks to Icha for getting the braining on what to say, brainwave for this idea. So some of you couldn't be part of it today due to some personal engagement. I'll sure Pasan she'll be happy to hear about the program. Once again, thank you all. We'll keep in touch, sir.
Thank you.
Bye-bye.
Thank you,
Thank you
sir.
for your time, sir.